the femoral artery size, and is there any tortuosity and calcification at the puncture site and aortic calcification. This gives important information whether the patient is suitable for femoral approach or any other approach we need to follow, or we should send the patient for surgery. If the patient had severe aortoiliac disease, he may not be suitable for transfemoral TAVI. We may need to choose other modality of treatment in these patients. So this is a summary of these things. Patient, after diagnosing aortic stenosis, patient has to be thoroughly evaluated, and based on the symptoms, ECG, echo, and cardiac CT. And next comes the heart team discussion, including cardiac surgeons, cardiologists, interventional cardiologists, patient and their family members. So we need to decide which therapy is suitable for the patient. So if the patient had high flow, high gradient ACE, that is high gradient ACE, we need to assess the flow status. If the patient had high flow status, and it needs to be reassessed because it may be falsely high gradient. We need to reassess after stabilization. And if the patient had normal flow with high gradient ACE, we need to give we need to consider it as severe ACE. And if the patient had low flow, low gradient aortic stenosis, we need to, with the valve area is less than 1, we need to assess if there is any increase in flow reserve with the low flow dobutamine stress echo. And there is increase in flow reserve with the patient aortic valve area is less than 1, that is an indication for this patient is diagnosed with severe AS. Then choice of therapy will depend on the other risk factors. So if the patient is diagnosed with severe aortic stenosis, then we need to choose the therapy, that is TAVR or SAVR. So it depends on the various factors like patient related factors, procedure related factors, and processes related factors. With the patient age depends on the comorbidities, life expectancy, and patient preference, and procedural risk, that anticipated complications, and peri-procedural risk, anatomy of the valve, operator and institutional experience, and other important thing is processes factors, that is whether it is mechanical valve or tissue valve. In tissue valve, whether it is surgical valve or bioprosthetic valve, depends on the heart team discussion. So initially it was only surgical AVR since 1960. Almost 40-50 years, only surgical AVR was the standard therapy. And in surgical AVR, whether it is mechanical valve or bioprosthetic valve, depends on the patient age and other indications or contraindications for oral anticoagulation. Since 2002, the first TAVR was implanted, and based on that, it got approved in 2011 for patients who are at high risk for surgery. And later on, it intermediate and patient got approval in almost 2015. And 2019, even low risk patients got approval for TAVI in selected patients, not in all. So these are the landmark trials that has brought TAVR therapy into the limelight. That is Partner 1B trial, initially for high risk patients, and Partner 1A trial, TAVR plus surgical AVR in high risk, and the Partner 3 and adverse low risk trial, that is in low risk patients. So then we need to have a risk stratification. There are various online tools, that is STS, predictor of mortality scoring, and Euroscore 2, and these cannot be applied in total to every patient. We need to have a heart team discussion along with the patient, and we need to consider other factors that are not in the risk scoring. That is, if the patient is frail, these are not considered in the scoring systems, and as well as anatomical factors that have a serious consequences on surgical AVR, that is like porcelain aorta, previous chest radiation, and patient had mitral valve disease. So these are some of the comorbidities that favors the therapy. Prior mediastinal irradiation or ascending aortic calcification, these favors TAVR, and the patient had severe aortic occlusive disease. For transfemoral, the other modality, other access sites may be used, but these are not in guidelines as of now. It may be come in the upcoming guidelines. And if the patient had severe MRTR that requiring surgery, or if the patient had valve morphology unsuitable for TAVI, then the SAVR is preferable. And some of the patients, even SAVR, surgical or TAVR may not be suitable if the patient life expectancy is less than 1 year. The patient had severe COPD requiring home oxygen therapy, severe irreversible pulmonary hypertension, severe heart dysfunction, hepatic dysfunction, and severe frailty. These patients